Well, I'm going to be talking about cellulitis first of all. It's going to just spend about 10 or 15 minutes talking about cellulitis, hopefully give you some hot tips on cellulitis. And then I thought it might be a good idea to talk about skin procedures for the practitioner, basic skin procedures that I think all primary care physicians ought to be doing. And that includes not just family practitioners, but also internists as well. There's no reason that general internists can't be doing these procedures as well. If we've got if I talk fast enough and we got enough time, I might talk about burning mouth, but I actually might skip that one so that we can spend more time on the Kahoot and some things that we'd like to talk about afterwards. Dr. Loeb mentioned some items this afternoon that she asked me to perhaps devote some time to, but we'll see how things go. We'll actually be looking at 25 different entities, skin entities, when we do our Kahoot. So first of all, a few cellulitis pearls. And what I'm going to do is, first of all, tell you what's not cellulitis. And then I'm going to tell you about something that really is cellulitis. And then I'm going to give you a brief update on empiric therapy of cellulitis. And then I'm going to bestow on you the greatest cellulitis pearl ever. But first, a case. A 70-year-old man presents to you with 3 weeks of increasing redness and swelling in his legs. And his spouse reports that he's had a fever. What's the temperature been? I don't know. I didn't take the temperature, but I know he's had a fever. He felt warm, right? And this is what he had. And what you can see, I'll point with the pointer here. You can see that he has a rash on both legs. It's erythematous and it's crusty. And sure enough, when you push on it, you note first of all that there's some pitting edema, but also it hurts. Patient says it's painful when you push on it. And a close-up of the back, and right here you can see kind of a splitting of the skin. With some redness. That's called erythema craquelé, and we see that in skin that's dry, but we also see it sometimes in people who have venous insufficiency, and then this crust on the surface. Here's this crust, and if you culture this, you'd probably grow out staph from it. It's unlikely you'd grow out strep, but you'd probably grow out staph, and that's because just about every ulcer that is on the that patients will present with, if you culture it, it'll grow out staph. So, is that cellulitis? Is what that patient's presenting with cellulitis? And this is a paper that was published about 4 years ago that I'm going to use just to highlight a few things. Inpatient dermatology consultation aids in the diagnosis of cellulitis among hospitalized patients, a multi-institutional analysis. And right now inside you're laughing, aren't you? Because first of all, you're wondering, is this some sort of self-aggrandizing? I mean, advertising for inpatient consultation? And the other reason you're laughing is, when was the last time you got a dermatologist in the hospital to do a consult? You know, I mean, it ain't going to happen, right? Now, I do